Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Hello and welcome back to the Low Carb MD podcast. I'm like a little kid right now. This is so much fun for me. This is a person, Tro, that we have that I first heard in Denver. I was under a rock somewhere and I thought, oh my gosh, I was honored to share this stage with this person. And there's so much wisdom, so much great advice that, it's an honor to have you all the way from Brazil. Tro, you want to do the intro, man?
Yeah, absolutely. We have an amazing guy. I've been following him on social media for a long time. He's got a massive Instagram presence, Facebook, Twitter. And I first saw him talk several years ago. It was a lecture on low carb myths. And I'm like, I think it was like 2017 or something. Today we have a urologist by the name of Dr. Jose Souto. And he's absolutely done amazing work, and watching this lecture, tackling the myths of low carb a couple of years ago was goosebumps for me. And then I saw it again, kind of an expanded talk in Denver this year. Sorry, Brian, he blew you out of the water. But it was just an amazing lecture, and you can catch it on Diet Doctor. And so very inspired by everything he's doing. And some of the new work that he's doing is something that hopefully we can talk about, creating a curriculum and a certification program for healthcare providers so that they can become educated about the low carb approach. This is truly amazing work, and I'm very happy to have him on today. Doctor, can we call you Jose? Dr. Souto, can we call you Jose?
Oh, yeah, sure. And thank you for the very kind words, guys.
Yeah, Jose. So can we? Before we got started, we talked a little bit about how you were exposed to kind of the low carb lifestyle. Can you talk a little bit about that? How you were exposed? How do you get started with this? And then, I'm certain as a urologist, you probably get asked, well, is this going to kill my kidneys? Am I going to get a kidney stone? You probably get all these things all the time. So hopefully you'll share some urologic wisdom for us as well.
Yes, okay. So it was by serendipity. I was listening to a podcast, and it was not a podcast about nutrition. But anyways, the guy that was being interviewed, and this is 2011, was Gary Taubes. And I have never heard about him. But, well, everyone that has heard him talk, he's like very smart. And I said, wow, I've never heard or read really anything about this low carb stuff. So I downloaded his book. It was a new book at the time, the book Why We Get Fat. And when I read it, I couldn't drop the book. I finished it on one weekend. And on Monday, I was doing low carb myself. Now, I was a little overweight. Actually, I had a BMI of 29, so yeah, almost obese. But I was not looking for a solution. I thought I was fine. And then suddenly I tried this low carb diet, and I lose 15 kilos. This would be what in pounds? Almost like 30. In 3 months, no hunger, easily. And I was like blown away. And I practically changed careers because of this book, because of reading Gary Taubes' book.
Yeah, that's something that we hear all the time is people were exposed to either Nina Teicholz or Gary Taubes, and maybe they had some weight to lose like me. Maybe they just had a little bit to lose or they had appetite issues. I can't tell you how many doctors I've met who said to me, I never got obese, but my mind was obese. Mm-hmm. I was so hungry in my mind, and we're highly functioning. We can go exercise. We can compensate for it. We can try to restrict, right? Most doctors can do that, right? but you don't know what's going on in the mind. And some physicians have come to me, these, absolutely, you look at them, they're just beautiful people. They're like, attractive and slim. And they're like, Gary Taub's book completely helped me. And I'm like, what? I was like, you never had a weight issue. Look at you, And they're like, yeah, it's not a weight issue. It's a hunger issue. So we've heard that before.
Yeah. So after I had this experience, I started reading everything I could about this approach. First, the books, then the papers that were cited in the books. And when I saw the amount of literature we had, randomized controlled trials, even the big epidemiological studies, I've learned that fat's gonna kill you. And then I got exposed meta-analysis that showed that there was no correlation between fat in the diet and heart disease. So how come I learned it the way I did? So, once we start going into that rabbit hole, it becomes never ending. So I started talking about the stuff to friends. You have this period where you become like you're a preacher. Everybody that you talk to, you need to tell them about this discovery. And I had a friend, doctor, anesthesiologist, that whenever I would talk to her about this new paper I was reading, she would tell me, you don't need to tell me. I am already convinced. You need to tell the world. You need to write about it. So I started blogging in 2011. And as I was telling you guys before we started recording, it never crossed my mind that people would actually read it, because I thought, okay, it's fun for me, but it's just me talking about clinical trials and papers. So who's going to read it? It turns out that a lot of people had interest in low carb, and there were no good sources for them in Portuguese at the time. So that's how it got started in Brazil.
Wow, 2011. Yeah, 2011. I was even thinking about this stuff back then, right? So
you were prescribing statins and
yeah, that's what I was doing. Saying, gosh, I wonder why my
right?
patients are getting sicker and I keep throwing more drugs at them. Oh, well, that's just the way it is, because this is a chronic, irreversible disease, right? And as a urologist, it's kind of outside your area, so that was intriguing to me when I said, what's this urologist going to talk about? So from a urology standpoint, what kind of things have you seen with people on the low carb? Because one of the biggest fears people have is that their kidneys are going to shut down somehow if they eat more protein. And also that they're going to get a lot of kidney stones and those kind of things. So, and uric acid, I think, is a huge topic. And I know you have a lot to say about these things. So I would love to hear your standpoint as an expert.
Yeah. And are my kidneys going to fail? Just let me. I've been doing this 6 years. Are my kidneys going to fail? My creatinine's gotten better. So just let me know, because I want to prepare.
No, they are not going to fail, definitely. I have a good friend that is a nephrologist, and he also does low carb and does low carb with his patients. So he runs a big dialysis clinic, and he used it to tell me that in 20 years, he has never seen a patient go into dialysis because he or she ate too much steak. What brings people to a dialysis clinic is diabetes and hypertension, which are things that you can actually reverse with a low carb diet. So it doesn't actually make any sense. The thing is, what people know, what doctors think is, when I have a patient with end stage kidney failure, he or she cannot tolerate large amounts of protein. Well, but they cannot tolerate large amounts of anything, potassium, even water, because their kidneys are not excreting well. So what I said, I think in the lecture you saw, is it's just like if you say somebody that has a very weak heart cannot tolerate exercise, so exercise is bad for the heart? No, exercise is excellent for the heart. The fact that a very sick heart cannot tolerate it doesn't mean the exercise caused the heart disease. So protein does not cause kidney disease. As for the uric acid, The thing is, in other areas of nutrition, we make the same confusion about what you eat and what happens. So we all know, and it's been known since the 50s, that the cholesterol you eat has very little, if any, impact on your blood cholesterol. But people have been advised not to eat eggs like forever because of the belief that because eggs have cholesterol, you shouldn't eat it. Now, the fact that meats and fish have lots of purines, which will be turned into uric acid, makes people think, okay, you shouldn't eat those if you have gout or high uric acid. Turns out most of the uric acid you have is produced by your own body, especially when you eat sugar, fructose, because the way fructose is metabolized, you need to produce a lot of uric acid. So the amazing thing is the diet that every doctor, every dietitian has learned to prescribe for patients with high uric acid, a low purine diet, has been tested in a randomized controlled trial only 3 times, as long as I know, and it has failed all 3 times. So we are prescribing something that has not been proven to work. And the thing is, most patients with gout, with high uric acid, they actually have the metabolic syndrome, and they will get better if they lose weight, if they reverse their insulin resistance. So yeah, it's a lot of confusion.
Well, and also it may be that you get more predisposed initially on a low carb diet, possibly because it's the change in uric acid. So if I treat someone with allopurinol, for instance, I go very slow, because if you change that uric acid too quickly, boom, gout attack while you're lowering it down. So, that may be something that we're seeing early on, and then over time, people do better at handling uric acid, getting rid of fructose in their diet, as Dr. Lustig has said. And I'm glad you reassured us that Jason Fung hasn't been lying to us as a nephrologist, that he's not seeing kidney failure on people who eat more protein.
Yeah, he's not lying, definitely.
What I would like to talk about, because look, now I have an expert urologist here, so I have to talk a little bit about kidney stones. So, I have seen data that early in a low carb diet, and I tell all my patients about this, that the urine calcium does increase, okay, and certain electrolytes do increase, and it seems to be that those normalize after several months. Okay, but certainly in the beginning, it increases. And I've seen also data that weight loss can increase the risk of kidney stones. So I stress the importance of hydrating. I think diluting the urine, it makes sense. Can you help me understand, is there a unique risk to an increased kidney stones with a low carbohydrate approach? I believe that there may be, okay, in the setting of weight loss. And what do you do? What do you recommend let's say you have somebody who's got recurrent stones, let's say calcium oxalate stones, or who knows what. Okay. How do you approach this? How do you approach preventing that stone, or should I not even care? Tell me how, us lowly internists, we're not as smart as you nephrologists and urologists,
Oh, I see.
So we're not as smart. So tell me how, we see a stone and we're like, yeah, just go to them, but how should we think?
Okay, so the first thing is, if you look in terms of associations, having kidney stones is associated with overweight, obesity, insulin resistance, diabetes. All those things are associated with a higher risk of having a kidney stone. So I believe, it's not been proven, but I believe that after you lose the weight, after you are metabolic healthy, your probability of having more stones is probably less, okay? But putting that aside, if a patient has recurrent kidney stones, he or she should be studied metabolically to see why the stones are being made. One of the things that helps is a 24-hour urine study, in which you will measure the calcium, the oxalate, the citrate, which is very important, And once you measure those things in a 24-hour urine, if there is something that you can fix, you should. So you will diminish the probability that the person will have other new stones. Now, if the person has excess calcium in the urine, sometimes when you go on a low-carb, higher protein diet, you may excrete more calcium. That's true. Not because the calcium is coming from your bones, let's make it clear, it doesn't. But because when you eat more protein, you absorb more calcium from your gut. So it's actually good for your bone health, but since you are absorbing more calcium, you are excreting more calcium. And in patients with hypercalciuria, which means a lot of calcium in the urine, sometimes you need to medicate them with a diuretic that will decrease the excretion of calcium in order to fix this. As I told you, and this is anecdotal, but after the person is metabolic well, has lost a lot of weight, sometimes you can take the diuretic out and it will be fixed because the person now is much better in terms of metabolism. So there is some truth that you may be excreting more calcium as you eat more protein. And as for uric acid, then it is important to make the urine more alkaline. This can be done by eating more vegetables, drinking some lemonade, which has citric acid. And there are some citric acid supplements that sometimes we use for patients with uric acid stones. So yeah, sometimes you need to do some supplements or medication to fix it. But it happens also in patients that are not doing low carb. So this is not specific for patients that are on a low carb diet.
See, I told you, Brian.
Well, yeah, no, I've seen all this stuff, and then also, you know, a lot of times they told people if they're getting calcium oxalate stones to stop eating calcium, and then their stones got worse because the calcium binds the oxalic acid in the gut and washes through without being absorbed more. So the low calcium may actually hurt people sometimes. Does that sound right?
It is true. This has been shown in more than one study, and it's one of those things in nutrition that if you try to do what sounds like it's going to work, you know, like you have fatty liver, so eat less fat. No, it actually doesn't work that way. So you have calcium stones, eat less calcium, and it can actually hurt you. Yeah, you're right. So although people that have a lot, that make a lot of calcium stones should not overdo calcium, but they should eat normal calcium. They should not, they don't need and shouldn't decrease it, because the calcium will, the body needs it. It will take from your bones if you don't eat it.
Great. Well, while we're below the border, what about this low testosterone that we're seeing and BPH, enlarged prostate stuff? What's your experience with a low carb diet in managing these two issues?
Wow, it is amazing. I see it on a weekly basis, patients that have low T. And once you put them on a low carb diet and they start losing weight, their testosterone will sometimes double without you needing to replace it, you know. So the thing is, inflammation reduces testosterone. If you have a lot of belly fat, it happens. Being overweight by itself, because you have this enzyme aromatase on the fat tissue that converts testosterone into estrogen. So once you lose weight, you have less estrogen, and estrogen, what it does is it goes to your pituitary gland and shuts it down, so you produce less testosterone in your testes. The thing is, many men with a low testosterone, they will actually restore their normal testosterone just by losing weight, and I see this regularly on a low carb diet. So usually, if the patient has a very low testosterone and symptoms, then I will replace testosterone temporarily, because you want him to get better early. But if he doesn't have symptoms, I tell him, okay, just let's focus on the diet, on the exercise, and wait some months and let's repeat it. And it's amazing.
Yeah, we're seeing a lot of that, particularly with the testosterone. One area that I've thought about theoretically, it makes sense that the prostate size. You know, I wonder if there's any evidence showing. I know certainly that insulin resistance is linked with higher BPH, but I wonder if a low carbohydrate diet would have any effect on benign prostatic hyperplasia, you know, just like an enlarged prostate for the regular listener who wants to know what that is. So any thoughts on the interplay between metabolic disease and a low carb diet and BPH?
As you said, it's linked. We know insulin is a growth promoting hormone for the prostate, both for BPH and prostate cancer. You can't grow prostate cancer cells on a petri dish if you don't have insulin there. So, and you have IGF, the insulin-like growth factor that goes together with insulin, and it's important for both BPH and prostate cancer. That being said, I don't think that you can actually treat, make the prostate shrink just by going to a low-carb diet. So the thing that I believe, and I'm not sure it would be a wonderful study to be undertaken, is if you could put people on a low-carb diet when they are younger, maybe, and I believe so, their prostate would not grow as fast or as large, because I believe it's one of the consequences of insulin resistance. But this is just a belief, because we have papers linking it, but we always say that association is not causation, right?
How about if we move up to stones like gallbladder, and you guys have any input on that with low carb ketogenic? Because that's another question that comes up a lot. I know it's outside your area of expertise, but you're an expert in all these areas as an internal medicine doc.
Okay, so we all know that once the patient has gallstones, a fatty meal may trigger the pain, because you know when you eat fat, it will make the gallbladder contract to expel the bile. And once it does it, if you have a stone, the stone may become impacted at the outlet of the gallbladder, and it causes pain. Now, what makes up the gallstones? It's the bile that's being staying there for too long, not being used, because the person doesn't eat fat. So eating a low-fat diet actually is a risk factor for having gallstones. And there is a randomized controlled trial of people losing weight with a low-carb or a low-fat diet. I believe the paper was people that had undergone bariatric surgery, but then were kept on a low-carb or low-fat. And the ones that were doing a low-fat diet, they have a very high incidence of forming new stones, but it didn't happen to anyone. It didn't happen to a single patient that were on the low-carb arm of the study. So yeah, we know that a low-carb diet will prevent the formation of gallbladder stones. Although once you have them, sometimes you need to go into surgery to remove your gallbladder. I've seen in social media, you guys may have seen it, people that say their gallstones disappeared after some time on a low-carb diet. So I'm not sure if it happens actually.
Yeah, we have medications that dissolve stones. They're just not a great long-term option if the diet doesn't change. Mm-hmm. That's the issue. I mean, if you look at the literature, I've done a dive into gallbladder disease. A refined carbohydrate diet literally causes stones. Not enough healthy fats will cause stasis in the gallbladder and will lead to stone formation. So it's the carbs that cause them, and then the fat that expels them. Right. So if you have certainly fat does expel it. We know that it churns the CCK, which contracts the gallbladder and also promotes satiety. But what I find, the way I guide patients is, if you've had a stone, a low fat diet may make it worse in that it may expel out, or if it's small enough, it may pass on its own, or it may redissolve. And certainly there's medications that can be used, but you're right, most of the time it ends up in surgery. Most of the time it's I had somebody contact me, their stone was 2 centimeters. I said, don't expect diet to dissolve a 2 centimeter stone. That's probably not gonna, that's like that's almost the size of a golf ball, well, maybe half of a golf ball, So,
Well, and as that stone shrinks, you're more likely to block the duct, because if it's too big, it's not going down the duct, right? So sometimes as you're shrinking down a stone could be the most dangerous time to get another one.
And also, if it's small enough and it passes, you may end up with a biliary pancreatitis, which is dangerous, right?
Yeah. So it's a challenge. The mainstay of treatment, guys, just so you know, for a gallstone, if it's symptomatic, is generally to remove the gallbladder. But that results in a lot of problems for people. And sometimes people are just fine. Other times it can lead to some issues, digestive issues. But yes, there are medical approaches. They're just not good.
All right, since I can't stump this guy, Tro, I tried my best. But let's go back south of the border again with interstitial cystitis. Do you have any experience with treating this with the low carb or ketogenic diet?
Oh man, that's a tough one.
Yeah.
For those that are listening, interstitial cystitis is a inflammation of the bladder that is not caused by bacteria. It's not your regular cystitis, which is a urinary tract infection that you treat with antibiotics and it goes away. Interstitial cystitis, usually the way it's described, it's a unknown cause. You have inflammation, you have pain. Once the bladder fills, the pain gets worse. And it's interesting. For some years now, I've seen patients that get better or worse depending on what they eat. And it kind of makes sense, because some of the things you eat will turn out in your urine. And the theory is that in interstitial cystitis, you have a greater permeability of the lining of the bladder. So usually people that are into low carb, they've heard of leaky gut. So this would be like a leaky bladder. And if the bladder was impermeable, which it should be, stuff that your kidneys are putting out, like potassium, like acids, shouldn't hurt. But if the lining of the bladder is partially permeable, then, acid will hurt us the way it hurts if something acid like lemon juice gets example. So if lemon juice gets into your hand, it won't hurt. But if it goes into your eye, it will hurt, because the membrane of the eye is permeable. So many treatments that urologists have proposed, they are local treatments where you have installation of things that will make the bladder less permeable, but you need to repeat that installation. It kind of works in some people. And I've seen people getting better with a diet that has no grains, low acid, not much hot things like pepper. It's a imperfect science. It's not easy. It's like if you ask a neurologist about headache. It's never easy. It's a world in itself. You have many causes of headache. Some patients get better, some patients don't. There is a book, if I remember, it's called the Better Bladder Book or something like that. By a nurse, actually. That book is very good, and it goes into all the diet modifications that have been tried to make interstitial cystitis better. So the answer is yes, people do get better once you dial in their diet, but sometimes you won't cure it, and it's not easy. It's not an easy issue.
Yeah, and clinically, I've seen stress being a big factor. You know, maybe they're just more sensitive. The nervous system gets more sensitive under times of stress. But I see people, they really will complain a lot when they're stressed.
Yes.
You know,
Yes,
every chronic disease seems like it gets worse with stress, Brian. I have to be honest. Migraines get worse with stress. Chronic pain gets worse with stress. In fact, you know, CBT has been shown to reduce depression in diabetics. You know, cognitive behavioral therapy, psychotherapists, it's been shown to reduce A1C by about 0.5. So I think stress and stress management, it like helps anything. And specifically if you have medically unexplained symptoms, right? So I view interstitial cystitis like a medically unexplained symptom, right? I mean, do we really know what causes it? I don't think so, right? So yeah, I think whenever you're in that realm of a medically unexplained symptoms, it's like stress management is very key.
Yeah, IBS gets worse. I mean, there's so many things, blood pressure. There's so many things that get worse under stress. So that's one of the things we talk about a lot. It's not just what you're eating, it's your lifestyle. It's stress. It's like not killing yourself, running around like a nut. Since we're still south of the border, what about urinary tract infections with these SGLT2 drugs?
It's definitely an issue. And
let me step back real quick, so for people don't know what it is. It's a medicine that when your blood sugars go up higher, it makes you pee out more sugar to lower your sugar levels, right? So that's what we're using a lot with diabetics these days. Can increase risk on a ketogenic diet of ketoacidosis. But you know, one of the big things I noticed clinically right away is my patients started getting a lot of urinary tract infections. People who've never had them in their life are all of a sudden having them.
In women, you see more cystitis, urinary tract infections. In men, sometimes what you see is the balanitis, balanopostitis, which is the infection on the foreskin. And, you know, because bacteria and germs in general, they love sugar. So once you put sugar in the urine, you are making it a growth media for them. So it is an issue. For some patients, though, the medications are really good. If you have a patient that has very high insulin, so the guy is insulin resistant, is diabetic, but has a high insulin, which means even if you give this kind of drug, the patient is very, very unlikely to have this diabetic ketoacidosis. The ones that I worry about is the ones that are insulinopenic, which means they produce very little insulin to begin with. These ones should not receive this kind of drug. But the thing is, for most patients, if they really adhere to the diet, you are probably taking meds off instead of giving them more medicine, right?
Yeah, and I think that's a huge issue. I mean, that's one thing. Sorry, Tro. The West Coasters can cut off the East Coasters once every year. You know, I think it's an important issue, right? Because this is the point. If you don't check an insulin level, you don't know what you're treating, right? The treatment may be the same, but you don't know, and you could put your patients at major risk. This is why I keep hammering this point of know your insulin level. Of my labs, fasting insulin helps me significantly in managing my patients and what approach we need. If your insulin's low, you got to put muscle mass on pretty much, right? And you got to cut your carbs. If your insulin level is high, you got to cut your carbs and put muscle mass on. It's still kind of the same treatment, but some of the medical management may change significantly based on this.
Oh, definitely. I actually, it is very hard for me to understand why doctors don't usually order insulin tests. Because, you know, if you are treating thyroid, you measure TSH. If you are, you know, treating any other gland, you measure the hormones. But now you are dealing with a problem that involves a gland, that is, you know, your pancreas. But, you know, you just measure the surrogate, which is glucose in the blood, and you don't measure how the thing is working. I mean, is the problem insulin resistance and you have a high insulin, or the problem is the beta cells that are not working anymore, You want to know, it is so basic. I was talking to a endocrinologist, and the answer he gave me is like, well, why we will order a test that will not change your practice? Like, we don't have a drug to lower your insulin. I was shocked, you know, because one of the things that is more fascinating is getting the patient that has a very high insulin, and a couple of months after you reorder the insulin and it's like half of what it was, and you show it to the patient, and you know, you give him a good feedback that not only he or she is losing weight, but he's getting better metabolically, and you can track it. So yeah, it's amazing. People usually don't order it.
I just had a patient. Her initial insulin 1 month ago was 81.5. Now it's 15 in 1 month, right? And her A1C's dropped 2 points in 1 month. 1 month in a 3-month test, right? So it's way lower than what we're seeing. And so you show that to a patient and they're inspired now and they're ready to go. They see that they're reversing their disease process and they have that in their control. And I think that is so critical. You know, because the weight can be a liar a lot of times, but you see your insulin numbers coming down. And Tro, I'm gonna have some good data, man. I'm gonna share it with you. We're gonna have some, you know, maybe a glass of wine and talk about this stuff because it's really cool what we're seeing. And I know Tro wants to have a question. We got the guru here, Tro, so we're both like trying to jump on each other.
I think, well, so here's the thing. We talked about two things, and it leads into another question. We mentioned the cautious use of the cautious and appropriate use of SGLT2 inhibitors. We talked about the implications of low carb dieting on some possible adverse events. We've talked about, you know, some of these nuanced lab findings. And all I can think about is how we need to help educate doctors, because you just pointed out, you know, that most doctors don't even know how to interpret insulin and the trends of insulin and what it means. You know, if they don't have a drug for it, what's the point of testing it? That's how they think. Mm-hmm. So, you know, I think one of the responsibilities for people like you and me is to, and Brian as well, and all of us really, is to educate, right? Is to educate. And so that's something you're doing, and I'm fascinated by it. I want to learn more about it, and I'd like our listeners to hear about it, because I know you're passionate about educating and now certifying providers, or at least providing an education series on what is a low carb diet and what we need to do about it. And if I'm not mistaken, you're the president of the Low Carb Association in Brazil.
Yes.
So tell us what's going on in that field, because, you know, I think we've beaten around it, but we've talked about it here, right? How should doctors look at SGLT2 inhibitors? How should doctors approach lab testing? So how are you approaching educating and certifying?
You're right. We have a Brazilian low carb association. I'm the president. The association intends to spread the science and the knowledge about low carb, having a presence in social media. We also have a PR person. So when there is a new low carb trial, for example, then she goes to the newspapers with some news pieces. You know, so we try to make it reach, you know, a wider audience, not just preaching to our own car. Now, myself and Rodrigo Bomeni, which is a very dear friend, a endocrinologist, we did this diabetes course, which has several online classes, starting from the very beginning and going into the nitty-gritty of, you know, the tests, the medication, and it's for both patients that are diabetics, for people that are interested, and for healthcare providers. And those that are healthcare providers, after they finish it, if they want, we put them on a low carb friendly healthcare provider list in Brazil. So we now have some, I think it's some 150 people there already, registered dietitians, physicians, physical educators, and patients can find them in their own state or city. And it's because, you know, you guys know this, it is very hard for a patient that's trying to change his lifestyle. And then when he goes to the doctor, doctor say, you know, you are gonna kill yourself, stop this crazy stuff. And patients complain that although they know what they should eat, they are doing it, they lost the weight, but they still need healthcare. They still need a doctor that will help them with their medication, with ordering the right tests. So we are trying to put those together. This program that we are creating, it is not anything official. It is not like CME accredited in Brazil yet, but we think we are going to make it happen in terms of accreditation. It would be great.
I think that's so valuable. I think the most important thing we can do is look to educate our doctors. And I think the fact that it's a not-for-profit and that you're looking to become accredited is probably going to be a great thing for our field and for doctors, you know, who want to use this as lifestyle.
Yeah, and we're going to kiss up to him so we get invited to Low Carb Brazil sometime.
Oh yeah, you can be sure.
I hear they have good steaks in Brazil.
Especially in this area where I live. Because, you know, when people talk about grass-fed meat, almost all meat in Brazil is grass-fed, you know. I was talking to a patient of mine that he raises cattle, and I told him, you should put a seal saying grass-fed, and he said, but okay, but it's all grass-fed anyway. I say, yeah, but now, now people are valuing it, and they read that it should be grass-fed, and people are confused. They think that, you know, they see documentaries in Netflix, and you know what I'm talking about, those vegan documentaries, and they should know that most of the meat that they will find in Brazil in the supermarket is actually grass-fed.
Yeah, and that's funny because when I was in Cuba, these guys were laughing. This guy was a chicken rancher, and he goes, "You Americans are crazy. You guys raise your." He was telling me all the statistics, and I was pretty amazed. He said, "All of our chickens are, you know, they just eat bugs and stuff like that. We don't feed them that garbage and chemicals and all this stuff like you guys do." And then you taste the chicken and say, "Wow, there's a huge difference, right?" But they're not like a 17-pound chicken breast over there. It's a lot different than what we have, right? Because they're not chemically altered. But like you're saying, that's natural, real food. That's how we should be eating. So it's pretty,
Yeah.
you know, yeah.
Chicken here is kind of the same way it is in the US. But as far as cattle go, yeah, most of it is grass-fed.
That sounds great. So when are we coming, Brian?
Yeah, we got to make this happen, man. I'm excited already. We're inviting ourselves. It's like we're inviting ourselves to our friend's house for dinner, right?
Yeah, let's
I'm trying to do that with
talk.
Ariel Ortiz right now. Ariel, are you listening, man? So, hey, again, anyone listening who speaks Spanish, Vives en Dietas is Christian Assad and Ariel Ortiz. They're doing great work. So, you know, anyone who has family members or friends in Latin America, get them out there.
We need to get a Portuguese speaking podcast.
That's the next one, man. We have our new candidate.
We have to we have to recruit Dr. Souto, and we can get a Portuguese, you know, low carb podcast going.
Yeah, it would be great. We have a lot of good people that we can ask for this Portuguese podcast.
Yeah, I've certainly seen you very active on social media, so it wouldn't be so far-fetched.
Excellent.
Yeah. Any other words of wisdom you want to tell us about, and also let us know where to find you, where people want to track you down and find you in Brazil if they're listening. We've got a few down there listening. Yeah, we'd love to hear any other, like, really what you think is important that we know, that our listeners know, and also how do people track you down on social media or wherever they're going to find you.
Well, you can find me on Instagram as JC Souto. But usually I'm posting in Portuguese as well as in my blog, which you can easily find on Google. But again, it's Portuguese. So where you guys will find me speaking something, retweeting something in English is Twitter. So JC Souto in Twitter. And I would like to thank you very much for inviting me. It's a real pleasure and honor to be here with you guys. I always listen to your podcast. So I'm very, very happy.
Yeah, it's our pleasure to get your insights. And I know the listeners are going to just absolutely love this, hearing about stones, BPH, kidney disease. I mean, these are the questions that people have. The education is invaluable. We really have to thank you for taking your time. The work you're doing is just absolutely amazing. This education and certification, I think, is an amazing thing, and it needs to grow. And, you know, hopefully we can mimic your program here in the United States, because I know, you know, Doug Reynolds is actively working on that along with some other people. So you're just doing amazing work. Thank you so much.
Thank you very much.
And thank you for helping us to help our patients, because what we take from you and learn and reassures us about things we're doing that in your area of expertise. So hopefully we can educate some of the urologists here in the United States to understand these things and just help patients, really. I think it's so great. But man, you were great in Denver, and you know, it was something. It really, you know, your talk was really, I was like, wow, really blown away. So thank you for all the great work you're doing, and for joining us, two lowly docs here, to talk about this stuff, because it's really great, and we're excited about what you're doing.
Yeah, you're too kind. Thank you. Thank you very much.
And everyone, thank you for sticking with us. You know, thank you for your support and for keeping us going, so we can have great docs like this on and just talk about it, you know, free of corporate payments and all that kind of stuff, and just bring the truth. It's an honor for us. Tro, do you want to close this, man?
No, just look, this is amazing. Dr. Souto, this is going to be so helpful. And Brian, I can't, you know, it's always nice to go through this with you, this journey with you, have these brilliant minds come together, and we get to learn from them. It's truly an amazing journey. Thank you to all our listeners.
Thanks.